All right, everybody. Looks like we have everybody coming in. Welcome. The Southeast MHTTC would like to welcome everyone to our webinar event today, Tele-education and Tele-mentoring in Rural Settings, Project ECHO, and Other Approaches. My name is Emily Moore, and I will be moderating today's webinar event. And I'm also joined by Southeast MHTTC Director, Dr. Ben Druss, who is going to be co-moderating and helping to introduce today's speaker. Before we get started, I'd like to note a few things. One, that the work of our center is supported by a grant from the Substance Abuse and Mental Health Services Administration, or SAMHSA. And two, that our center and the larger MHTTC network use affirming, respectful, and recovery-oriented language in all of our activities. A few words about our center before I turn it over to Dr. Druss. The Southeast Mental Health Technology Transfer Center is proud to serve the 8 states, excuse me, in HHS Region 4. Our expertise in public health programs, systems, research, and evaluation provides a unique lens through which we can address mental health priorities. We encourage you to visit our website at mhttcnetwork.org/southeast to learn more about our center and upcoming events. Before we get started, please note that this event is being recorded and will be made available on our website for on-demand viewing in a few days. We also encourage you to share your comments throughout the presentation using the chat feature. And if you'd like to chat with everyone, please make sure that your chat feature says chat with all attendees. We've also allotted time at the end of our presentation for Q&A. If you'd like to submit a question for Dr. Raney, please use the Q&A feature at the bottom of your screen. And finally, for any participants who are interested, we do have a certificate of attendance that's available for download after you've completed our SAMHSA required evaluation survey. And with that, I'm going to go ahead and turn it over to Dr. Ben Druss so that he can introduce today's speaker.
Hi, everyone. Thank you so much for joining us today. It's a very important topic in general and for the Southeast in particular. It's my real pleasure to introduce Dr. Raney, a longtime colleague and friend. Dr. Raney is a board-certified psychiatrist and principal with Health Management Associates in Denver, Colorado. She's a leading authority on the collaborative care model and bidirectional integration of primary care and behavioral health. She is the editor of a number of books, Integrated Care, Working at the Interface of Primary Care and Behavioral Health, and Integrated Care, A Guide for Effective Implementation. She's published a number of articles in peer-reviewed journals on topics related to integration. Importantly for today, Dr. Raney was born and raised in North Carolina. She has returned to Asheville to train residents in the collaborative care model as part of the North Carolina area health education centers. And as you'll hear, she also has lived for many years in rural Colorado, so has expertise and experience as a rural psychiatrist. So we're really looking forward to Lori, to your presentation today. With that, I'll hand it over to you.
Thank you, Dr. Druss, and I'm really happy to be here with folks today. I just want to go over a few objectives that we're hoping we'll be able to accomplish today, really looking at the rationale for using telehealth, understanding the limitations of telehealth in rural and frontier communities, and some possible solutions. And then what are some key concepts you might use to set up your own telehealth program? What I'd love to do is, we've got a nice sized group here today, is if you guys don't mind, in the chat box, let us know what telehealth you're using right now. And with COVID, we used all kinds of things. So whatever you used when you were remote, what are you using now? What are you keeping? It'd be really helpful for me as I go through to see what you're currently doing And we can actually maybe expand on that a little bit too. So if you guys don't mind putting that, if you don't put anything in the chat box, I'm going to think maybe this group isn't using any telehealth, in which case, hopefully this will give you a wide variety of options in your program. But I have a feeling most of you are using a little something out there, even if it's just telepsychiatry or teletherapy. So Dr. Druss mentioned that I'm born and raised in North Carolina, and I was actually raised in a very small tobacco farming community in Bladen County, which is about an hour from Wilmington, down in the Sandhills of North Carolina. And after my training at UNC, I moved out to the West and have pretty much been here most of my 30-year career. And I put these little stars on the map. So when I first started, it was in Arizona on the Navajo Indian Reservation, which looks a whole lot like this. Big red rock country, vast swaths of area with few, if any, people. And we call it, there's rural and then there's frontier. Frontier, I think, is less than 15 people per square mile, and rural is more like less than 50 or something of that nature. But way out here, really in a frontier area on a reservation where we had very little telehealth of anything. And when that stint was over after 7 years, I moved right here in the corner of Colorado. So if you've ever been there, Durango's here, Mesa Verde National Park is here. And I've basically lived and worked there up until just this past year. So that in rural area, I grew up in a rural area. I'm at home in a rural area. And this picture here at the bottom is the view out of my kitchen window in my home in Colorado. I won't show you what my place in Asheville looks like, because now I feel like I'm a city girl and I got to figure that one out. But very, very used to being in very rural areas, a long way from Denver, 8-hour drive. I take a plane. It's too long to drive over the Rocky Mountains. So very much just familiar for many of you who are working in rural areas between here and Florida and Alabama, very familiar with where you're working and the obstacles that you may have. Although I will say, in the years that I've worked in these locations, a lot of new technologies have been provided, have come on board. So it's been really, really nice to be able to incorporate things as they became available for our rural communities. Now, you guys, I'm not telling you anything new about the workforce shortage in rural areas. It's actually very difficult to get staff out there for reasons we'll talk about in a minute. But I do want to show at least a slightly hopeful slide. Dr. Druss, I don't know if you've seen this yet. You probably had, because it was in psychiatric services last week or the week before. But through expansion of the National Health Service Corps, we used to have this much more difficult map with many, many more dark areas in it, where we didn't have even a single mental health center person serving in lots of counties across the country. National Health Service Corps did absolutely help us at least get some folks out there. So this map used to have a whole lot more dark areas, but it still has plenty. And these dark areas are those areas of highest vulnerability in terms of not being adequately staffed. And you can see over here in the South, where we all are, we still have issues and concerns about workforce shortage. Again, I'm probably not telling you guys anything new. I'm really tickled to see grad students and others that are in the chat, because my hope is that you will come to work in your communities here in the South and be able to tick off a couple of these dark boxes. We want to turn all these dark boxes into light boxes so that we can say we have some therapists, psychiatrists, advanced practice nurses, that we have these folks working in all of these communities that we can. There's all kinds of reasons why. This photo is taken about 10 miles north of where I worked in Arizona. When I first moved out west. This is Monument Valley. Some of you may have been there before, but again, you can see just vast geographical areas. And you may notice out here, there are no poles that would bring electricity out to these homes. There's no water lines, and there's no cell phone coverage. Although when I first got there weren't cell phones, but much at all out there. So you can see just rural and a lot of challenges, especially on and tribal lands, at least some of the tribal lands that are more remote. But, you know, for folks moving out, and even for me, who's your community of colleagues? How are you going to get continuing education? What about treatment options? You know, when I went out there, there are no ACT teams or day hospitals, or just a number of the treatment options weren't available. There's limited social options for your staff. When they interview with you, they're going to ask what they're going to do on the weekends. A lot of these small towns roll up the sidewalk around 9 o'clock. The distances to more urban areas, I was 2 hours from Flagstaff, which was the big city, and about 5 hours from Albuquerque, which is where we tended to fly in and out of. So imagine 5 hours one way just to catch a plane. And then, of course, limited technology ownership, you know, cell phones, internet, and then abilities around using that. It's the younger, you know, folks in our communities that have a lot more access and expertise with technology. I certainly, if I don't know how to do something, I go ask someone under the age of 50. And in particular, it's my 24-year-old daughter that I'm asking how to turn on my computer, lately my printer, and she knows more tricks with my cell phone than I will ever know or ever want to know. So that's just kind of how it ends up. So these are a lot of the challenges in getting and filling in that map, as you guys know, but also the challenges out here, again, are the rural, the distances, and the lack of the technology solutions. What we're going to talk about today is really looking at a range of opportunities. And I haven't quite got to artificial intelligence yet. AI will be the next thing I add to this graph, and I'll probably put it, they all know, somewhere in here. But that's really one of the up and coming things that we're seeing right now, you know, sometimes with its problems, as we've seen with some of the newer AI technologies that have come out in the last couple of weeks and some of the articles that have been written about them. But what we're going to work through here is starting at the left. If you're in a rural area and you don't have enough staff, and you don't have what you need to provide behavioral health services to folks, and even if you do, these are nice compliments. What are those patient-facing technologies? And we're going to talk about remote symptom monitoring. We're going to talk about just, you know, what that self-management looks like. Remember, patients spend, let's see, if they come in once a week, that would, in which they don't, but that'd be 50 one-hour sessions with you a year. Imagine there's a lot more years in or hours in the year where people are doing their own self-management. They're home, they're taking care of their diet, exercise, whatever it is. So we're going to talk about self-management. We're going to talk about practice extenders in the way of text messaging and apps, and then also digital therapeutics, what's happening out there with remote other technologies, and then kind of moving into how do we support our staff, okay? We're going to talk about clinical decision supports. How do we, when you have a positive PHQ-9 question 9, and when you have, you know, something going on, you got a person with depression, and maybe your primary care doctor are not sure what to do. What might those decisions, how can we help folks with algorithms and whatever? How can we help with consultation platforms? We're going to talk about eConsult. We're going to talk about Project Echo. And when we get to Project Echo, I'd be really interested in any of you that have had this, because Project Echo has just spread across the country during COVID. Actually, starting with the opioid epidemic, Project Echo got heavily funded across the country. And then with COVID, even more funding came in. We're going to talk a little bit about how you can provide care remotely, where you may have all of your staff in a central location, or providing something like collaborative care model, which can be done a lot by telephone and remote teleconferencing. And then what I tell people is the last thing you should consider is telepsychiatry, which is what most people start with. They go, we need a psychiatrist, let's do telepsychiatry. So to think about in Burgundy here, it's really that directly seeing patients face to face. That doesn't help with the workforce shortage. It might help geographically with your workforce shortage, but we only have so many social workers and therapists. We only have so many psychiatric providers. If we move some around with telehealth, it doesn't really help with the whole bucket that we have. And one of the things we're actually seeing right now is so many of our new graduates are being just grabbed up by these telepsychiatry companies. And it's really, really exacerbating the workforce shortage that we have in rural countries in terms of needing at least some warm body psychiatric providers in your clinic. And again, a lot of that's being done by telehealth, and I'd be curious. So let's go through these a little bit. And I'd be really curious if you guys have something you're using, pop it in the chat box, because I'm really curious. There are 15, 20,000, probably closer to 30,000 apps now for mental health. That is the booming area. It is where the venture capital folks and the hedge funders and the series ABC, I don't even understand it, all that venture capital is just pouring in for these companies, and much, I think they call it irrational exuberance, a lot of money coming in and a lot of money being spent, and some of it works and some of it doesn't, and little overnight companies becoming worth billions of dollars in the course of months. So there's a lot of backing of these companies. It's typically not done by folks that are clinically oriented or even behavioral health oriented. It might be someone whose brother took his life, and they were really concerned about the amount of care. He couldn't find care, so they're gonna start an app where you can, on your app, text someone and get help, and maybe even have your medications delivered. So there's just so much going on in the self-management space right now, and I think they're good places for it. Fitness reminders, Fitbit, Strava, there's all kinds of stuff like that. Diet reminders, calorie counters. I have my grandson did a lot of calorie counting and nutritional work. He was overweight and he lost like 30, 40 pounds. I was amazed. He did it all on an app on his own with no guidance. He found it himself and just did it. A lot of stuff out there. We don't know what's harmful and what's helpful on some of this stuff, but I was really tickled to watch what he did. You can do things like behavioral activation goals, patients punching in, I'm going to go swimming next week. And then next week getting a ping, did you go swimming or not? Really kind of working with people on behavioral activation, which is extremely important if you're depressed. Affirmations and reminders. There's just all kinds of ways that self-management technology can be used. And this is where there's just a huge explosion. And like I said, we're not sure what helps, what can be harmful. Lots of studies going on, the FDA scratching their head about what to do around this, because it's all done under the thoughts around medical care to some extent. And there's also concern about who owns the data. Like if I'm on my Fitbit, well, Fitbit owns your data. Who really owns this? What are they doing with it? How are they potentially manipulating the data to either get you to sign up for more stuff or to actually shoot ads your way? So, it's not all nice researched in the medical academic arena. It's coming from all over the place. So although there can be a lot of good stuff happening with self-management technology, some of the things that I've mentioned, I don't know if you guys use Headspace or anything that you find helpful. But we aren't quite, we aren't quite sure where it is in terms of safety of everything. So you do need to really assess things for safety and who keeps the data and that sort of thing, and price. Some of this stuff's free. I think you get a lot of junk ads if you go for free, and then some of it you actually have to license, and you pay for the license. We see this going on with a lot of big insurance companies now. They are licensing Headspace and Beat the Blues and Livaggo and all kinds of different apps, licensing it out to their staff, either companies, their HR department, or Medicaid, like state-wide Medicaid. We see it happening in all kinds of places. But there's definitely a role for self-management technology, and it helps you in your mental health center because your patients have something else that's going on outside of those visits that they have with you, either for psychiatric med management or something like individual psychotherapy or group therapy. All right, so let's talk about a form of practice extenders, and this is remote patient monitoring. How do you measure symptoms, keep track of people, know that they are taking their medicine, their weight is stable, their symptoms are they getting better, are they getting worse, are they getting the same? So one example is, many of you may be doing measurement with the patient health questionnaire 9-item, the PHQ-9. If you have depression, if you have a diagnosis of depression, it's an okay measurement tool for how folks are doing. One of the biggest problems we have is getting patients in on time or getting them in at those time intervals. So at least once a month, we want to really be tracking this until people are well. And so one of the things we're seeing is a bunch of companies now where they can actually send a PHQ-9 out on a text, and a patient can very quickly fill that out and send it back. So whatever it is we're doing, whether it's when they come in, we make the diagnosis, that's our baseline. We do some treatment. Maybe it's medication, maybe it's therapy. And then we reassess. We ping out there about a month, 3 weeks to 4 weeks, ping out there, send them a PHQ-9, they fill it out, it comes back to us. And then if they're not getting better, what it does is really prompt us to change care. And that's really the beauty of measurement-based care in behavioral health, is that people aren't getting better. Right now we say, well, how do you know someone's getting better? And they say, well, they're smiling more. And that's nice, but that won't get you very far in the healthcare field in terms of, really thinking about change and how you're going to report change to payers to say, well, they smiled more. Really got to have some hard measurement. And this is really helpful. And it's nice they can go on patient portals. They can do it on apps, phone calls. And it's nice to let patients do it themselves, not to have a medical assistant or someone or the doctor have to sit there and read this stuff to them. It's time consuming, and patients tend to be a little less forthcoming, I think, than if you leave them alone in their quietness of their space and let them complete a PHQ-9 or a GAD-7 for anxiety or a substance use measurement tool on their own. So this kind of practice, extenders and measurement, remote monitoring is really exploding across the field. You can connect your blood pressure cuff, you can connect your scale. There's all kinds of ways. You can weigh people so that you can know, if they've got congestive heart failure, if their weight's going up, that can mean fluids accumulating in their lungs. Just all kinds of cool things going on with remote monitoring. So the other practice extender that can be helpful for you in the behavioral health setting is remote therapies. And I'd be curious if any of you are using these yet. So cognitive behavioral therapy is the #1 therapy. If you look online, that's the one you see the most. There are a few studies of CBT that have come out that have shown that it's looking pretty positive, some with interpersonal therapy, behavioral activation, some substance use treatments. There are all these different remote therapies that you can use. The problem that we found with them is, yes, it's an evidence-based treatment. Yes, it can be helpful, but after, there might be 12 modules in a CBT set. After about 1 or 2 modules, if you're just leaving the patients alone to do it, they stop. There's a drop off. So what we've learned is you can't just send people out there to do CBT on their own. There's this just drop off in motivation. That it needs to be, you need to have someone that's kind of the prompter, the case manager. So if you have a therapist that's referred a patient for online CBT, that therapist needs to call, check in, and they need to notice, hey, I noticed that after the second module, you haven't gone back on. Is there some barrier to that? So they really do need that human touch, reminding and encouraging and discussing how that online therapy is going with them. So that's definitely been one of the downsides of this. And again, there's plenty of free, but in a lot of cases, actually, you as the behavioral health provider would license this. So you would pay up front and give your patients access to a portal where they could go in and do CBT. And you can imagine in a rural area, if you don't have, you can't recruit therapists, you've tried everything you can to get a licensed person out there, and now you use an online therapy, and they're doing this in all kinds of ways. Video, it's really nice to be able to video your therapist. You guys can look at each other, but there's also places now doing texting and emails back and forth between a therapist in one location and a patient in another. And then, of course, artificial intelligence. What's that going to look like when the patient's literally, interacting with an avatar or a remote appearing, therapist? And, I just don't even know, know what all that's going to look like at the end of the day. But I'm hopeful it's going to help us solve the workforce shortage. No matter how hard we try, even though there's a handful more of psychiatrists going into medicine, we don't have enough. We're never going to have enough. We don't have enough therapists. We don't have what we need. So how might this actually supplement what you're doing, as long as someone's still paying attention? So maybe instead of a 1 hour psychotherapy visit with one patient, maybe in 1 hour, you make 5-10-minute phone calls where you're following up on someone who's doing interpersonal therapy or CBT online. So that might be a way for you guys to think in your rural areas how technology could be a problem solver for your particular workforce shortage and for the needs of your patients. Sometimes you can't offer patients what they need. You may not have you got adult therapists, you don't have a child therapist, and CBT is one of the main treatments that we're always looking for kids. That's where the majority of the bulk of the research is. So maybe you could figure out how to do remote CBT through an online CBT for adolescents, for example. So these are things I think we all need to explore and watch the studies on them. And then some of this stuff, I think Beating the Blues is one where they do CBT, and I don't have any financial support or involvement in any of these companies, but some of the ones I've heard about people using Beating the Blues, because it's one where you can go and do online CBT. So again, nice potential solutions here. The challenges, of course, are payment. If you're going to license it, how does your organization pay? Maybe you use all those vacancy savings, we used to call it. Maybe you use vacancy savings, take a social worker's salary and turn it into a license for one of these. Bandwidth, what do your patients have out there? A lot of people have 70-80% of the population has a smartphone, but do they have the data? Do they have what they need to actually be able to interact? If it's not bandwidth, what about texting, email? What does that look like? And then this, I mentioned before, the security of the data. Who owns it? When you do your Fitbit stuff, all that goes off somewhere else. When you do 23andMe, all that data goes off somewhere else. Who owns this stuff? What are they doing with it? And that privacy issue, what's HIPAA compliant? That privacy stuff makes some of us a little uneasy because we're not exactly sure what's happening with it. Okay, so the next piece of thinking about technology is now, okay, so now I do have therapists, whether they're remote or on site. How do I help them so that they don't have to think they have to refer a patient somewhere else? How do we build stuff, hopefully, into the electronic health record that can help in the moment? So if, for example, if a primary care provider that you're collaborating with gets a high PHQ-9 or an audit C or GAD-7 on just routine screening in their clinic, what's an algorithm that they can use? Here's a high PHQ-9, confirm the diagnosis of depression confirmed, yes or no, yes, okay. And they then open up a laundry list of potential. So one of the things you can do is start an SSRI. One of the things you could do is refer for therapy. One of the things you could do is refer for remote therapy. One of the things to do is to rule out, is this a thyroid problem, anemia, something else? And so it begins to give that algorithm to the primary care providers, because they'll chase down a whole lot of medical stuff before they think about, hey, this is depression and we need to do something about it. The other thing that can happen here is the patient can be suicidal. They can have a positive on question 9. And a lot of our primary care and other folks, they're out in the middle of nowhere. And if you want to help them so they don't have to refer that patient to your community mental health center, how might you have algorithms to actually help them? What would that look like? How would what are those referral sources? In your algorithm, you could have referral sources if there's something they can't get, and make those referral sources something in the community. Don't come up with things, for here, if I said, go to Denver and do this, most people aren't going to go. I need to figure out what's in my community. What does this look like? And then just to make sure that you're incorporating evidence-based practice. You don't want to just buy anything off the street without you making sure that this is a really nice, it's good for your patients and what you have going on. So clinical decision supports can be used for primary care. They can be used for your psychiatric medical staff. They can be used for your therapy. They can be used for your peers. And again, you're building in these supports so that that treatment for the common, less complex issues can be taken care of right there. And your mental health center, your behavioral health facility isn't being bombarded by referrals from primary care, for example, that could be handled out there if they had some technology solution like clinical decision supports to do it. And in these certified electronic health records, they actually have to have some sort of clinical decision support. When ours first came out, we had to pick one, and we picked tobacco use. And so every time I checked yes on smoker, I would get this pop-up for all the different options for tobacco cessation. The other one we had was child BMI. So every child, and almost a lot of our kids were overweight, would always pop up this algorithm for what to do about, nutritional counseling, all this stuff. You got to be careful. You don't want it to get to be a whole bunch of white noise. You don't want too much stuff. But what might that look like in your facility? And what is your electronic health record actually capable of doing? It's nice if you can build it in. If not, you could have a laminated piece of paper and have the algorithm on it if you need to. But it's really nice to have it as a technology solution. Okay, so in this category of, building that expertise in your community, either building it up in primary care or building it up in your behavioral health setting, Project ECHO has begun to sort of fill a void that a lot of communities have had. And I'd be curious in the chat box if any of you have been involved with Project ECHO, because it's so, and you can see over here, there are a number of places actually in North and South Carolina, Florida, New Orleans, where we have what are called these kind of hubs for Project ECHO. The mothership is over here in Albuquerque, New Mexico, and there's another one up in Washington State. So are there places where there are the huge hubs and then smaller hubs all over the country, and you can see kind of what you have here in the South. But if any of you doing Project ECHO for anything, even if it's not mental health, if you guys would pop that in the chat box, I'd be curious. But Project ECHO started in New Mexico, where they had one gastroenterologist working in Albuquerque. They had tons of patients with Hep C who needed treatment, and that one gastroenterologist could not, no matter what, treat all those patients. So people were dying on the waiting list, waiting to see him. And it's actually pretty simple treatment. It's a medication that patients can be given over time that can actually cure the problem. So what he decided to do was to figure out a way to use televideo out to these communities and train the PCPs in how to treat Hep C. Okay, so what he did was he sat in Albuquerque, and then he would beam out, and I'm going to show you a picture of this in a minute, to 10 or 15 primary care clinics. The primary care doctors would talk about their patients. He would tell them, how to do it. He would do a didactic portion. So they were able to sort of start and successfully treat Hep C out in the community. So it started in gastroenterology. So, the whole idea of there's not enough specialists. So ECHO begins to train these primary care providers to do it themselves. And what they actually found out was for Hep C, the viral load for treatment was the same if they were treated by these primary care docs as it was in academic settings where it was being treated by PCPs. Very effectively figured out, how to do this. So I live pretty close to Albuquerque, and so I went down and did the immersion training. Their whole saying is they move knowledge, not people. So for someone to have to drive all the way to Albuquerque, for those of you who've been in New Mexico, that's a pretty remote area. Trying to get people, if they ever did get an appointment, try to get them to drive in for these appointments was really hard. So move the knowledge out to primary care and get folks treated without all the travel. So here's just a photo of what this looks like. This is actually the gastroenterologist who started it. He is in what's called the specialist hub, and surrounding him is a psychiatrist, a nurse, a social worker, an internal medicine doc, a pharmacist. These guys are all sitting there in this hub at the University of New Mexico, and they are beaming out to 1, 2, 3, 4, 5, 6, 7. In this case, 7 primary care clinics are trying to treat Hep C on their own. And you can see Las Cruces, you can see some of these sort of remote places where they are providing this treatment to. And the primary care, they're doing some didactics, and then they are doing some specific patient cases that the PCPs will punt to each other. And for behavioral health, you can do all kinds of things. This is supposed to be depression, anxiety, instead of depression, FEP, first episode, psychosis, substance use, and in particular, like I was mentioning earlier, with the opioid epidemic, Project ECHO has been expanding out across the country to teach primary care providers how to prescribe buprenorphine all sorts of child conditions. If you're struggling with things in your community, what might these look like? And there are some real specific things around medicine, like Project Echo, epilepsy, that sort of thing. You can do Project Echoes around the use of clozapine or long-acting antipsychotics. And again, this academic hub is really helping your individual, either mental health centers or primary care clinics or substance use centers, really helping you guys learn how to provide this care for yourself and not having to refer folks to the big city unless you just refer the cases where you're totally stuck, not like Dr. Sanjeev here decided, not some of the easier ways of treating Hep C, but also, even more complicated things like just trying to understand first episode psychosis, really give people the care they need. Even if you're in a rural area, you don't have access. Well, here, we're going to start now having access because we're going to learn how to do it ourselves. The other cool thing that it does is all these primary care providers and folks, they actually get to know each other online, and it builds a community of learners, which I just think is very, very cool. Like I mentioned, there's didactics that go, so there's a very specific pattern to the Project Echo. It's usually about an hour, hour and 15 minutes. They try to do it over lunchtime, but it's hard if you've got multiple time zones. But they'll have very specific, usually about 15 to 20 minutes of didactics. So they'll take something like depression, you can see here, and divide it into a bunch of little snippets. Okay, so you get a little bit each time. And then there's the case presentations and the advice and stuff from the specialist. So this is just an example at OHSU, Oregon Health Science University. They had an echo for primary care providers, and you can see they knew every day, here's their echo schedule, exactly what they were going to be providing a snippet of education for. And you can see they took them a few to get through depression. They did some cultural competence, bipolar, all kinds of different things, trauma-informed care, how to do motivational interviewing. And all of this became, and there's actually a whole other set of didactics. I just made one slide. There's a whole other set of didactics of things that they did. So again, moving knowledge, not people, training people out in the field to do this work. The challenges, that time dedicated to weekly conferences, people get uneasy, we should be seeing patients instead of doing this. There's always that pull, the provider participation, PCPs, they're exhausted, and now we're going to ask them at lunch to sit through this and present cases. So sometimes that's been an issue, and certainly how to pay for it. It's mostly grant funded, some state funding, sometimes an insurance company will do it. But for the most part, it's do you have a grant or not? And if not, it's really hard. And what you're paying for is not the clinics, not the spokes, but to get all those specialists, a handful of specialists in the hub, you're paying for an hour of their time to be there. And that's where most of the expense is in the hub. Maybe you're doing the hub yourself as a community mental health center, you wouldn't have that expense per se. It's just your in-kind expense for your site. But that's just been one of the challenges of it. What about e-consult? So e-consult is where you might need a consultation from a specialist somewhere. And this goes both ways. A primary care provider might need a consultation on a person with depression. They've tried a bunch of medicines and nothing works. What should I use? Or you may be in a mental health center, and they actually started an e-consult program in LA where a psychiatrist who's got a patient whose blood pressure is high, whose feet are swollen, can do an e-consult with a primary care doctor and say, hey, what should I do next? So it's this back and forth exchange. It's not in real time. So the provider out in the field uses a portal, puts in their question, it goes to the specialist, and within a day or so, hopefully sooner, that comes back. So we call that asynchronous, okay? So it's a way to back and forth discuss the patient, knowing that answer may come back in tomorrow. And it's a really nice way to in an educational kind of way, build the competence of that provider over time. It has, it reduces those referrals to specialists. It reduces cost to patients. I mean, in terms of travel, I was talking to someone the other day, the family had to travel 2 hours one way for a child therapy session once every 2 weeks. Really gets that communication, that relationship going between specialists and providers. And you guys will have access to these slides. You can see a whole lot of things here. One of the cool things that happens is it reduces unnecessary referrals to specialists. So you've tried, a number of things, and if it works, great. They don't need the referral anymore. And so you'll actually see a lot of places, and even in LA where they've got all kinds of, folks, they set up a really nice e-consult system. It's important that the e-consult system, as we think about the challenges, there's some documentation. Yeah, the PCP has to get the consultant act on it. We do have a problem again with payment models. There are some CPT codes out there. They don't pay very much. The patient has to pay their copay, that kind of stuff. There's state regulations, liability issues. Where can the psychiatrist or person be? What state can the person providing the consultation in? They have to be in the same state as the patient. There's a lot of regulations across state lines that are just, they get us everywhere in the technology space. So there's a lot of things we need to kind of think about. We need to make sure we match the population. You might not need rheumatology e-consult, even though rheumatology is available. You want rheumatology? It's like, no, I want first episode psychosis. So we got to make sure. And again, a lot of technology companies are getting in on this. Rubicon, there's several others of them, and they're really getting in on this and really, trying to meet a need. But it just really, just raises issues of, are we covering state regulations? Are we covering liability? Everything went out the window with COVID. Everybody could do everything. That's all tightening back up now. And what can we actually do with some of these consultations? So it's really nice if you're potentially, your organization's providing the consultation for a primary care provider, for example. Maybe you need to, and sometimes people will just email or they'll text, or you may want to actually license just the platform to get this information going back and forth. So, just something to think about with the e-consultation piece. It's a cool platform. It's asynchronous. It's not like Dial-a-Doc, but it gives you actually a chance to attach articles. If the specialist can send information back, but it also allows the primary care provider not only their note, but they can attach labs and x-rays. And so there's really a really nice way to have a lot of information exchange that's a little bit more than maybe just being able to pick up the phone and call somebody. So it's nice, and it's expanding, which is kind of cool to see. So at the end of that spectrum, telepsychiatry, teletherapy, this is the direct one-on-one session that you're having. It doesn't have like, Project Echo, where you're doing so many providers and so much training who then apply it to their patient. This is one-on-one, and there's a place for one-on-one. Absolutely. There are patients that it works for and patients that it doesn't. I haven't had a whole lot of success with schizophrenia, and in particular, when we went to audio only, I don't know about you guys, but on the tribal lands where I work right now at Ute Mountain Ute, people don't have cell phones and bandwidth. So we ended up doing a lot more audio only, and doing audio only with someone with a psychotic illness is very, very difficult. So I ended up actually having those patients come to the back door of my clinic. I was in the clinic, had them come to the back door to really assess how they were doing. So you really do have to figure out, you got to match, who does technology work with and who does it not work with? And even potentially for someone with a, psychotic condition, is it actually making things worse because they're, worried about those texts and things they might be getting. Telepsychiatry, we had a great time during COVID. All the rules were relaxed about cross state lines. Now all those rules are tightening right back up. Their provider must have a medical license in the state where the patient is. So if you're in New York and your patient's in Wyoming, in a rural area, the psychiatrist needs to have a Wyoming a medical license to see that patient. So we also need to figure out, does that remote specialist have to be on site? Can they be in their place? Do they have to have a bricks and mortar clinic? California in particular has some strange rules about that. Is the patient going to be in the home, or is the patient going to be in the four walls of the clinic? Those of you who work in fairly qualified health centers, you may be familiar with the inside the four walls requirement for telemedicine, and then the changing rules. I mean, do we have to do an in-person exam with everybody? What are we going to do about controlled substances? So, all states are struggling with this. It'd be really nice if some at a federal level, someone would take hold of this and really sort this out and really help us with compacts for medical license, really getting the rules figured out. The public health emergency ends, I think, in May, and a lot of the loosening and rules that we had are really going to go away. And so what is this all going to look like after the enormous freedom we've had for the past 2 to 3 years in doing telepsychiatry, telemedicine across state lines? Just something for us to keep in mind and to think about as we move forward. Now, to me, one of the coolest things that happened during, again, COVID, we had a lot of skepticism. There was always, payers who didn't want to pay for telemedicine. They would use things like, well, maybe it doesn't work, all kinds of, I thought, interesting excuses, given that there was really good data that shows telemedicine is safe and effective for most folks. But what COVID taught us is, so this is a primary care provider. I think this is probably Doximity or Doxime. I can't remember what you called it. We used this when COVID first hit. This was one of the easiest platforms to get on. Your behavioral health person could be in their office or at home. Your psychiatrist, if you have a psychiatric consultant, could be anywhere, as could the patient. In this particular instance, this patient sitting in a clinic and talking to this behavioral health provider, and there you can use mobile apps maybe to get the PHQ-9 for this patient. After this behavioral health provider has seen them, maybe they use this app to follow up on some goals. And then you'll see sites that are using database called a registry so that you don't lose track of these people. And we were taking lists of patients, and at the first we didn't have any patients to see. It shut down all of our therapy. We hadn't quite figured all these different technologies out yet. So we would use our patient list to actually call patients at home, check in and say, hey, how are you doing? What's happening in your family? Are you having any COVID-like symptoms? Have you had it? What's going on? So what we actually learned, COVID taught us a lot about technology and how it can be used, and any of the skepticism, concerns about it, a lot of that really, we were able to challenge those assertions and really come away with, what, we can do this. We can use technology in all kinds of ways. And some of the tech companies are really taking advantage of, this whole potential of having sort of a telehub, of having a place where the, kind of like with Project Echo, we've actually seen kind of this hub where all these specialists folks are here and are able then to provide care to patients in their homes, patients in their clinics, that we really can do this and do it successfully, which is, I think, one of the just incredible silver linings of COVID. And where I work right now, we're doing hybrid patient care still. I work in Western North Carolina. There's a lot of hills and hollers out here in Appalachia. And we're still doing some combination of remote and in-person visits. We also have a room where a patient can come. If they don't have internet, they don't have remote, they can actually come and sit in this room. And if their provider's off somewhere else, and actually have an appointment with their provider. So we're providing the space, the bandwidth, the technology, like with the lady here in the middle. And so it didn't really matter where the behavioral health person or the psychiatrist was. Now they got the bandwidth to do this work. So I just think it's just really cool that there is a silver lining to everything that's happening, all the skepticism and all the naysayers around technology. We were able to actually test some of this out and prove that it can, in certain circumstances, be effective. Now, you always have to plan for emergencies. And I really, HHS has put out this just really nice brochure for us to think about in terms of creating an emergency plan. And it's a long document. I would suggest you guys, jump on that. Actually, if someone wants to put that link in the chat box, that might be helpful too. But being able to plan for telehealth emergencies. And one of the things that comes up a lot is doing the PHQ-9 and what if they're positive on question 9, that sort of question. And there's some people that one of their solutions is to do the PHQ-8, right? So that becomes the solution for what to do. What do you do? What are the other emergency protocols? How do you think about it? So, some of the things that we want to be doing when we're looking at telehealth is knowing where the patient is, what's the emergency, number for that location. We know 988's out there now. Who are their health professionals? Who's close? Who's their support person? Just really kind of looking around and making sure that people have the technology that they need, or that we know enough about people to know that there is that we can have a backup plan in case there is an emergency. And a lot of it is really, putting in place what you have, but what's that remote solutions? What's this going to look like? And for all of you, it's going to be different. Your communities have different levels of resources in your community. So just to really think about this and put this in a policy and procedure. This is our telehealth emergency plan, whether we texted someone, and this Utah has a really nice teen crisis text line, because that's what teens do. What happens if that teen is texts back that they're feeling suicidal? If they miss an appointment, could they be in crisis? Is someone someone's in a domestic violence situation, is it possible that the abuser is over their shoulder listening to what's going on, so the person is not very forthcoming? Those are really the folks that we found to come into our clinics because they needed to get away from this person in order to be able to get the care they needed, so that someone's not actually listening. What does this all look like? And I'd really, as you guys are kind of thinking about how you're going to use telehealth, what's that's going to look like, how do you put together a safety plan so that as you're using the technology, what you're going to do in case of an emergency? Some folks with things like the PHQ-9, they'll give it no more than 24 hours in advance, and then have a disclaimer on there. Please understand, if you're feeling suicidal, please dial 988 or go to your nearest emergency room or something of that nature. So just again, what's it going to be for you and your session? So that's just planning for emergencies is really an important part of doing this work. And I just want to sort of finish up with this slide, just to sort of have people sort of think about where technology fits into everything that we're doing. And I sort of see that there's primary care practices. Some are very sophisticated in doing integrated care and doing their own behavioral health work. Some, not as sophisticated, maybe more rural, like some of your communities, where they're just out there trying to coordinate with your specialty, with your behavioral health centers, doing the best they can. Some that may have more of a mix. And then over in your specialty behavioral health center, where you're treating potentially a large portion of the SMI population. Maybe some of you have become a medical home for the SMI population. Maybe you've become a certified community behavioral health center or CCBHC. Some of you may be very much coordinated with justice involved populations. Yes, folks come out, maybe they went in because they have schizophrenia, bipolar, or substance use problem. How are we thinking about providing services in our behavioral health and primary care systems? And what I want people to sort of keep in mind is there's this opportunity for technology to allow us to do a good job with all of this. And that includes, you can see, on the access to healthcare is one of the 5 social determinants of health: economic stability, the environment you live in, education, and your social connections and neighborhoods are the other 4. But even with, even addressing these social determinants of health, all have a potential technology solution. And the idea that we could have these consultation telehubs. Now, as I mentioned before, there's a lot going on outside of our systems, our traditional systems, with venture capital and other tech solutions coming in, Silicon Valley type stuff coming in, all these apps and things, and they're just kind of spread out. They're trying to get everybody to buy their product. If we can find some way of sort of thinking about in your region, in your state, how do we corral these services and have this consultation? Do we have a Project Echo? Do we have a pediatric access line? Do we have an app that we've licensed for online CBT? What does this look like? And making sure there's technology in all of these sites to be able to receive this information and, provide that to patients. That this consultation, this telehub, this idea could be located in your specialty behavioral health clinic. You guys mostly have mental health. You could run this yourself. You could do Project Echo out for primary care. You could license an app. There's a lot of interesting apps coming out to help people with serious mental illness, manage some of their physical health. I think Dr. Drush, you might be involved in some of that, but there's really just so many different ways as we really think about these linkages between primary care and specialty behavioral health and these special populations that each of us is trying to take care for when we are all in a position of not having enough staff to do this. To really think about where does technology come in helping us get this work done. So the other last thing I would say is use technology to take care of yourself. Here's my team in my organization during COVID. We just get together and have coffee hour. You know, what does it look like in your organization? Hybrid, in-person hybrid meetings going on now. How do you get together and talk? And how do you create a culture of technology solutions? And this is, wow, we're going to write some papers on this. We're going to learn. Everyone may have a story to share, but this is something that we really, really need to be thinking about how we're going to accomplish. Okay, that ends kind of the formal piece of this presentation, and I'd be curious if there are folks that have questions or comments about what they're doing. I'm not seeing anything in the let's see here. Okay, Dr. Druss is saying, to what extent are you seeing primary care providing telehealth to with the SMI in rural settings? I'm not seeing a lot of it coming from primary care, and I really wish we could. I wish we could do like Project Echoes around at least long-acting antipsychotics. I don't think we're ever going to get primary care providers to do something like Clozaril. I'm seeing them more doing depression, anxiety, PTSD, some bipolar disorder. There's a nice new study that's come out around treating bipolar disorder with collaborative care in primary care settings. So the SMI population's tougher. I think a lot of what we're seeing is some moving to treating the physical health of the SMI population by our primary care colleagues, thank goodness. Using telehealth to do it, of course, during COVID, we did have to have a lot more telephone and virtual conversations, but it's definitely a place that we really need to explore remote monitoring and being able to have that follow-up for sure. But the primary care, they understand that a lot of these folks aren't going to get care anywhere else. So there's definitely a push, but I don't think we're there yet in terms of feeling comfortable with primary care really willing to jump in and do more. I know we're about out of time. Let me see if there's any other questions. We got about 20 people on. I'm just curious if anyone had used we've got some teleconsultations going on. We've got some teletherapy going on. Good. So you guys, and I'm curious about the teleconsultations. Amber, I know you put that in the chat box. That's a cool one. I'd love to see what kind of consultations you're doing. And I see, people getting classes and webinars like the one today, kind of figure out what's going on. And I would just challenge everyone on the phone to think about, and you can put this in the chat box, we have a minute left. If there's any one technology strategy based on what you heard in this talk today, any particular strategy that you might want to use based on what you learned today. And if there's anyone that has anything in particular, or just taking that away to your team, I think that would be fabulous. And I don't know, does our MHTTC team have a final anything around the survey at the end?
Yes, thanks, Dr. Raney, and thanks for your presentation. I'm going to go ahead and ask Hannah to drop our required survey in the chat so that everybody can access it. There it is. And that's just the SAMHSA required survey that will let SAMHSA know how we did and let us know how we did today. That's going to conclude the webinar unless there are any final questions. And again, if anyone needs that certificate of attendance for their records, that will be available to you after you fill out the SAMHSA required survey. Dr. Raney, any final comments?
No, I just hope folks are able to think about how they might use technology to deal with workforce shortages and the incredible need out there in rural communities. We're out there fighting the good fight. Keep up the good work.
All right. Thanks so much, Dr. Raney. Thank you everyone for attending and participating. That's going to conclude our webinar for today. Thanks so much, everyone.
Thanks, everybody.